Thank you so much for hanging out with me a little bit this morning. I'm Anne. I'm a
Hi,
journalist in Denver.
I'm Siddharth. I'm a cardiologist in Houston.
Excellent. How long have you've been a cardiologist for a while? We're going to talk a little bit about uh, why you're interested in what you're interested in, because honestly, like having this, I'm doing a story on this, but having this disease myself, it's hard to find cardiologists who have know much. They know about it, but they're not super well versed in it, or they don't have a lot of patience with it. So what got you interested in aortic disease?
I became interested in it through my connection to genetic research because it is one of the most strongly inherited forms of cardiovascular disease that run in families.
So that's why you're like, oh, this is something that I kind of want to learn a little bit more about. What are some things that you've been working on when it comes to aortic disease? I know you do some research and you're kind of involved in like this exercise part of it too, which was really fascinating to me.
Yes, I started out by making discoveries when in looking for rare variants that cause aortic disease in families, and then extended that to other types of genetic variants that lead to aortic aneurysms and dissections in genetic syndromes that cause aortic disease, primarily in Turner syndrome, and also in patients with bicuspid aortic valves. And lately, that work has extended to understanding how those genetic variants may cause aortic disease by looking in cell models in the lab, taking these cells with these genetic variants and understanding how they make aortic tissue and why those genetic variants disrupt the process. So that was my genetic entry into aortic disease. And then, as director of the Aortic Disease Clinic since 2011, I've been building a practice focused on aortic conditions of all kinds, primarily heritable thoracic aortic disease, bicuspid aortic valve, and Turner syndrome. And in so doing, I've become interested in patient advocacy, working with advocacy groups that promote education and awareness about these conditions, and then developing patient-centered projects, which is where the exercise study came from. Since many of our patients have had aortic dissections, I noticed that they were being counseled not to do exercise after the dissection, and I wondered if this was actually true because we know in other conditions that exercise is beneficial. I was surprised to learn that there wasn't any evidence about this being beneficial or harmful in aortic disease. And so I've worked with my colleagues to set up some exercise studies over the years to determine first the safety of exercise, and then more recently, moving into exercise as a potential therapy for aortic disease.
As a researcher, because this is relatively recent research you're doing, does it sort of blow your mind when you bump into something like that that hasn't even been looked at?
Well, unfortunately, it's the case in most of medicine. 80% of what we do is not based on evidence. It's based on tradition or in the absence of available evidence in investigator or clinician gut instinct, which is surprising to learn, but that's still true today for most of medicine.
What have you when you've talked? Let's talk a little bit about more about your research. Has there been anything that's really surprised you, or anything that patients could find interesting about the research that you found, other than like you should probably be getting out there and exercising if you've got this?
Yes, so many people don't realize that aortic conditions do run in families. And so, probably the most important thing that you can do to protect yourself and your family members when anyone in the family has been diagnosed is to make sure that everyone, all the first degree relatives, that is, the close relatives, mothers, fathers, sisters, and brothers, and children, get screened for aortic disease. And that screening can take two forms, either imaging to evaluate the aorta or, and this is also extremely important, the availability of genetic testing has come to the point where every family should be offered genetic testing when someone is diagnosed. Unfortunately, we see that the awareness about that is lagging behind the discoveries. And so one of my missions is to raise awareness in the community of patients, but also clinicians about this fact.
How the heck do you do that?
In several ways. One, we trying to empower patients by giving them information to take to their doctors where they are, because we think that educating one doctor at a time is the best way to do this in real time when they're dealing with a patient that they obviously have a connection with and therefore are motivated to learn about. And then the second way is by creating educational materials for clinicians that are easily accessible and speak to them in familiar terms that cardiologists and surgeons can relate to instead of generic terms that were used in genetics textbooks that are hard to access for people without a genetics background.
Um, you're talking about awareness. Do you feel, have you seen awareness in the for this disease increase? Have you seen, I'm guessing the answer is yes to that. Do you attribute that to anything?
Yes, I think that my colleagues and I have seen a notable increase in the awareness about aortic disease. Primarily, this is due to medical schools teaching this subject to students and residents. For example, we were talking just yesterday about how on the licensing examinations for physicians, which are widely considered to be the standard for core of knowledge and fund of knowledge that are required for new physicians or to retain your license in practice, now feature questions about aortic disease, which was unheard of just 10 years ago. So it is true that people are being forced to learn about it as part of their training and certification, which is really the only way to ensure that there's a standard of care around aortic disease. And that's something that we're trying to enforce in all areas. So, for example, imaging. It is not widely known, but there are no standards for imaging the aorta that are universally applied across all disciplines. And so one of the struggles for patients comes in the diagnosis and also even understanding their condition because they're getting conflicting information from different doctors, including the people who are in charge of imaging their aortas. So we're trying to institute new standards that help both patients and clinicians kind of navigate this, the many different rules around this to make it clearer for everyone.
What's some of the conflicting information that you've heard of?
Well, there are different sets of rules depending on whether you're a kid, you're an adult, you're getting a CT scan, an MRI scan, or an echo scan. All of them have different rules for measuring and reporting aortic conditions. And even, for example, if you die from an aortic dissection, which we never hope to happen, but it does happen, unfortunately, there is no standard way to report even that a dissection occurred. And this has huge implications for the family, of course, because if the family doesn't know what someone died from, then there's no way to warn other people in the family that they could be at risk for a fatal aortic dissection. And so that's something we're working again with another set of professionals to try to fix. But these things require huge interinstitutional initiatives across disciplines, and that's been one of the reasons why it's so difficult to move the needle in clinical practice.
You said about 10 years ago, people started being forced to learn about this. Why did that happen? Do you know?
Well, a lot of it has to do with the work of folks on the educational committees of professional societies. So, for example, I serve on the education committee in the Marfan Foundation. They're a major provider of education to clinicians and patients about aortic disease, and they have instituted this outreach to different specialties, radiologists, physical medicine and rehabilitation individuals, primary care doctors, and cardiologists to incorporate this into their training programs. And I think over the years that has paid off in what we see now in terms of increased emphasis on aortic disease and all kinds of training programs.
I mean, that's something that people should be, I don't want to say excited about, but that's a positive step in the right direction for people diagnosed with this. What does the future of treatment for this disease look like? Like in your magical unicorn world, that what could happen? What's your hope in the treatment for this disease? Do you see things on the horizon?
Yes. So the current focus is on automated detection of aortic disease for everyone that comes to the clinic or the hospital. And the way this would work is that there are deep learning methods. For example, anyone who gets an electrocardiogram, there are artificial intelligence-based tools that will be able to detect aortic disease signs in an electrocardiogram, and then prompt the clinician to order an imaging test. Or if you come in for the hospital for any reason and get a CAT scan, which happens with increasing frequency, and you have an enlarged aorta, there'll be an automated detection that says, hey, this person may have an aortic aneurysm.
You're talking about AI, um,
Yes,
and then it stopped. Then you froze, and then you were done. So you were talking about interesting things that are kind of on the horizon right now, or happening that are new.
right. So the premise for this is that we know that individuals who are diagnosed early, either due to having a family history of this condition or serendipitously getting detected due to another imaging reason, do better because they can be started on medications that prevent dissection. They can have their blood pressure controlled. They can be followed and have elective surgery to prevent fatal dissections. The real challenge has been detecting the disease before it causes a dissection. By automating detection, we would essentially be able to capture many more individuals at an earlier stage of disease and therefore prevent deaths. So the current focus has been to develop these tools and embed them in other clinical systems where people might come to the hospital to get scan or imaging or even an electrocardiogram and have a warning that is generated by an automated system that tells clinicians they need to investigate for a potential aneurysm or condition. And this would be a game changer for even with the current treatments we have, because we would be detecting so many more of these individuals when we can do something about it.
That's wild. That's happening now, or it's going to start happening.
It's happening now. Yes. We expect that this to be routinely available within most large EMR-based systems within the next 5 years.
That must make you feel good.
Yes, it's an exciting time. One of the challenges then is to train a new generation of clinicians who's interested in aortic disease, because we're going to have many more patients in the short time, which I'm trying to warn people about, but I don't think they see it that way. Aortic aneurysms are actually way more common than we thought, because as we're starting to screen more, we're finding more. And so the incidence rate has been going up. And it's not due to the fact that the disease is changing. It's due to the fact that our ability to detect them in asymptomatic people is much greater than it was 25 years ago. But if you look at the world incidence maps, especially in Europe and the US and North America in general, the incident rate appears to be rising for that reason.
Yeah, I mean, people just tend to get scanned more for random things like myself. I don't think anyone would have looked at me, and my doctors would never have looked at me and said, "This is what you have. You have random middle-aged woman palpitations." And then they're like, "Oh, that's what that is." So I think it's interesting to read about those. It's not that that it didn't. We always haven't had these numbers of people with this. It's just that people are getting better medical care now, or getting more medical care now, and the scans are more accessible. I mean, mine was done in a calcium score, and
Yes, and
people
then
are.
of course the other major change has been we're recognizing dissections better. So in the past, even a generation ago, if someone died from a dissection, they were often said to have died from a heart attack, because there was no way to really distinguish those two things efficiently. Both of them can look externally almost identical. You grab your chest, you might collapse, and there was no way without an autopsy, which is still rare, to determine it definitively. But now, again, with imaging, we're detecting these dissections more frequently. And that's another reason the incidence is going up.
Is this fun to research?
No, it's great. It's my life's work, and I'm very passionate about it. So it's easy for me to talk about, but I know that it's not for everyone.
Yeah. But when there are these advancements, you must there must be a part of you that's just very happy, and to be at at the front end of something that, like you said, 10 years ago wasn't being talked about quite as much.
Well, it's very gratifying to be able to fill in some of the gaps that exist and to make sure that patients are taken good care of, which is really why I got into medicine, to address those kinds of issues where people feel like they have a resource they can turn to and they have some clarity in terms of what is going to happen and how things are going to be managed. That makes me personally very satisfied.
What do you wish people knew about this disease?
I wish they knew that it was treatable and controllable as long as you have a good diagnosis and are being followed regularly. Sometimes people think of it as quote unquote a ticking time bomb or inevitable, a death sentence, and I think that is overrated. In most cases, when we are aware of it, we can do something and we can manage the patient successfully.
What is some bad advice you've heard that people have been given when they've gotten this diagnosis?
I think the worst advice is to retreat and do nothing. I know in many years ago, the standard of care was to advise people to avoid all activities when they were felt to be at high risk for an acute dissection. And we know now that this has devastating psychological and physical consequences. So anytime someone has been told that, I work very hard to try to counteract that impression because I know that the outcomes will be much worse in terms of them developing physical problems, but also we see a very high rate of post-traumatic stress due to their medical diagnosis and anxiety. And these things can have a direct physical toll on the body, aside from what is going on with the aorta.
Um, and really, you already answered it by saying what's the worst. What is the best advice that you give people when they are diagnosed with this? Because more and more people are going to be diagnosed with this, as you said.
Yes, as a best advice is to make sure that they and their families are well informed about their personal risks of having an aortic condition that needs an intervention, that they're being monitored if they need to be monitored, and get, of course, genetically tested if that is an indication. But with all of that, that they can live a relatively normal life and expect to have a normal lifespan.
Fantastic. Is there anything else you'd like to talk about? What's on the horizon or what you've been working on?
I guess the most important thing that I want to develop is eventually a way to get more people access to the standard of care, which is all of these things we've been talking about. Unfortunately, care is still uneven, more uneven than we want. It depends on where you live and how close you are to access an aortic specialist. So we're trying to do two things. As I mentioned, we're trying to train more aortic specialists. That'll take a while. And then we're also trying to get patient or connect patients better with aortic care. And that's an ongoing battle as well. The Marfan Foundation has helped a lot. I also work with the John Ritter Foundation for Aortic Health. They do a lot with patient navigation. So developing aortic experts who can kind of hold people's hands after their diagnosis and direct them to care. But this is still a relatively painstaking individual process. And we're always constantly trying to brainstorm how do we reach more people where they are and get them connected with good care, because that's ultimately the goal.
Yeah, it could be easier. I can attest to that. Including forcing your family members to get tested. That finally happened. But yeah, I agree with all of that. And this was really interesting. The AI stuff is fascinating to me. I hadn't heard of that as someone who's getting care now. I suppose I've already been diagnosed, but that's something really interesting to pass on. And that's something that you'd have to get you'd have to be at a cardiologist almost though for any of that or at a hospital.
Well, we hope that routine tests that you would have with your regular doctor
But
could also be used to diagnose or flag someone who might have suspicious findings for aortic disease, and then you could be referred. The issue right now is that the vast majority of people, of course, who have aneurysms or dissections never see a cardiologist before it's too late. And so we can't expect that that would be routine. We have to have some way to prompt, their caregivers to pay attention. And the best way to do this, as I said, in a standardized way, would be to automate. So that's where our focus has been. Obviously, we're trying still to educate those providers, but as I mentioned, that's again, a slow process that will take many years to permeate the community.